So, as said in the standard meta-analysis, we combine studies to improve precision. How the different patients will vary different doses and things like that. So you're going to get heterogeneity, but you shouldn't get heterogeneity in a meta-analysis of baseline variables. So, such as this is a meta-analysis of the age of 23 randomized controlled trials, which, as far as we know, are robust studies. And as you can see, all the randomized trials produce an effect that's close to zero, with one or two effects tend to be smaller trials that move away from zero. But overall, you put them all together, you get I-squared of 0%, you get a tiny difference that's nowhere statistically significant. And that's what we'd expect if we took a random sample of 23 trials and put them together. We would expect this kind of finding. And a colleague of mine, Laura Clark, led a group of us to undertake a methodological review of meta-analyses, and she identified 12 meta-analysis systematic reviews. And this is what she showed, that rank them by I-squared. You see the first one there's 84% I-squared, so a huge heterogeneity when we're looking at age. And there's actually a statistically significant difference in age, which in this context wasn't the main point. The main point was looking to see if there was heterogeneity when there shouldn't be. So if you go down and look at all the 12 trials, we can see that only 4 of the 12, whereas heterogeneity is 0 as we would expect, and even one of those there is an age imbalance. So we know the null is true, because the null is supposed to be true, because there should be 0 difference on average between the two groups, and there should be 0 heterogeneity. But the fact 8 out of 12 there's a non-zero heterogeneity is really rather worrying. What can we do about this, apart from throw away the meta-analysis? I think is a bit extreme. So Amy Hicks, who's a junior doctor, sort of took one of the meta-analyses, and we developed a method of identifying those with the biggest age imbalance and slowly remove them one at a time from the meta-analysis until baseline heterogeneity no longer existed, and then redid the outcome meta-analysis. So that's one approach that you could do. So what should we do? If restricted randomization is used, we should avoid using small blocks. Mixing block sizes can help, though mixing blocks of 4 and 2 is worse than 4 alone. Don't block by center, as this enables predictability. Don't use sealed opaque envelopes. These are truly the pits of actual trial research. Should we actually do blocking or restricted allocation? Well, simple randomization followed by analysis covariance is just as efficient as blocked randomization followed by analysis covariance, which is what you should do in a trial anyway. So long as the sample size is above 50 or 100, simple randomization should give you what you want. Now I'm going to turn to cluster randomized controlled trials. Cluster trials were described in an educational statistics book by Lindquist in 1940. And he argued that education trials should, the natural unit of allocation there is sort of the school or the class, not the individual child, for obvious reasons. And there's a lot of health education trials use cluster randomization, and lots of guideline kind of trials use cluster randomization, so like randomized GPs or hospitals or periods of time. Unfortunately, they are seriously susceptible to selection bias. This is because we have 2 levels in a cluster trial. We have the unit of allocation, such as a GP practice, a hospital, a school, time or village, etc. And then within that, we have the individuals on who we undertake outcome assessment, such as the patient or the pupil. Now, the first level, cluster randomization, that can be done badly, as individual randomized controlled trials are done, or it can be done well. So it can be concealed, it can be done properly. Now, the second problem comes is quite a few cluster trials recruit patients after they've randomized the clusters. And if we go back to schools aren't such a problem when Lindquist was doing it, because he would have class registers, members of the school, they would be known, and then he'd randomize the schools of the classes, and then you would know who was in the cluster before you actually randomize. Sometimes this is perfectly possible in our kind of trials, but sometimes it isn't. Sometimes you recruit afterwards. So if you recruit after you've randomized the cluster, then everybody, the patient and the clinician doing the recruitment, knows the allocation in advance of recruitment. So you've got the same problem as if somebody had posted up the list of randomization techniques, list of randomization sequences on a public notice board. Everybody knows. And so you may consciously or unconsciously recruit people contingent on that knowledge, or patients may or may not decide to take part contingent on the knowledge of what they're going to get. So this is an example. This is a UK Beam trial. This was undertaken in the 1990s. This is where we were training doctors on how to manage back pain patients, and GP surgeries were randomized, and then the GPs were supposed to recruit patients to which we would test the outcome on patients to see whether training GPs gave a better outcome. Here we go. So we've got 26 practices, 13 were randomized in each group. They're quite pretty balanced on size. But if you look at how many they recruited, you can see that in the intervention group, 165, more than double that were recruited in the control group. And this is, in hindsight, perfectly obvious as to why this has happened, because we've trained GPs to identify and manage back pain, and so they would identify more patients. It's almost obvious that they would do so. And we look at the baseline character, and we see by the baseline characteristics of the patients, they are very in the intervention group have a better outcome at baseline in the control group. So had we continued with that trial design, we'd have shown that training worked because the patients were of lower severity than the patients in the control group. So it was a biased trial. As you can see, these are the recruitment graphs for that trial. We can see the from almost the start, there's double the number of patients recruited in the intervention group rather than control group. As part of this, we did a systematic review to see whether this was a bigger problem than that single trial. And so we looked at 5-year period between 1997 and 2002, and then published our trial, our study in 2003, showing that yes, about 40% of cluster trials that we could look at recruited patients after randomization or had some other problem where there was evidence of selection bias. However, is that the novel is the go-between said at the first of the novel said the past is a different country, they do things differently there, or do they? So were we doing things differently, and are we doing things differently today compared with back in the 1990s? Sadly not. This is a review undertaken by medical student Jamie Bolson, looking at cluster trials published in 2015 and 2017, and she found that of the 23 cluster trials she identified, nearly half are at high risk of selection bias. So things haven't changed in about 20 years. And she also went one step further than we did in the original review. So I've shown this slide before. This is what we should expect when we do a meta-analysis of age of randomized participants. We would expect an I-squared of 0 and no difference between the two groups. But if we did the same for cluster randomized trial, we see a really high I-squared of 93%. There's significant numbers of trials there. We can see that have either older or younger patients. The bias can go either way. And there's actually, if you actually looked at the age, there was a big significant difference in age between the groups. So that was and this is one of the trials from Jamie's review. This is a cluster randomized trial of infant simulators. This is where young women still going to school were randomized to receive an infant simulator, which is basically a young baby you take home for the weekend, and the simulator cries at random intervals, wants to be changed and fed. Basically, it's trying to mimic the hell of having a newborn child. And if you look at the outcomes of that randomized trial, it appeared to show that giving these young women simulated babies increased the risk of pregnancy in the next few years. So the level of teenage pregnancy increased. And if you look at the table on the bottom left here, you can see the p-values off the scale for whichever statistical method you use to look at the data, it's highly statistically significant that these simulators seem to be harmful if you give them to schoolgirls to try and prevent pregnancies. The NHS Choices website, the headline is "Baby doll simulators may actually increase teen pregnancy rate," and they conclude this trial had a good design and a suitable sample size. Well, and they went on a list of other issues that should be to be thought about. But the first part of that sentence, this trial had a good study design. Clearly, they were convinced by the study. Clearly, the Lancet referees were convinced by the study. And more importantly, the Daily Mail was convinced by the study. Lifelike baby dolls were designed to deter teenagers from having children, actually raise pregnancy rates. So we have a concordance of views between the Lancet, the Daily Mail, and NHS Choices that this was a rigorously designed study, and we should make sure we never let a teenager get hold of one of these babies. But is it true? We know NHS Choices and Daily Mail both agree, so that doesn't necessarily make it so. Let's look at the design. This is the CONSORT flow diagram. So when we randomize clusters, members of all members of the cluster are essentially part of the trial. So here in the control group, we see that 3,150 women were in that group, compared to which is 50%. So of the women who actually took part in the study, it was only 1,567, or 50%. In the intervention group, only 58% of the women took part in the trial. So immediately see two problems here. First of all, if this had been a drug trial, individually randomized trial, and we'd sent a paper to the Lancet saying 50% of patients never got the intervention, and they never gave us their outcomes, so we couldn't do an intention to treat analysis, then the paper would be immediately turned down, because it opens the gates to hopeless confounding, because you've got so much missing data. But that's not the end of the story, because there's a differential recruitment rate. So we have 8% more people in the intervention group than the control group. If we look at the baseline table, this is the table where we should look to see for problems. Unfortunately, statisticians don't like doing baseline p-values, and there's good reasons for that. In fact, when I teach trials, I say don't do baseline p-values, because the pointless waste of energy. I'm now changing my mind on this, and it's sort of a bit of a heresy if there's any statisticians listening to this. But if we look here, so because you can't see, things don't stand out immediately. If you look closely at socioeconomic status, for example, we can see that 13% of the girls in the intervention group belong to the lowest socioeconomic strata, compared with only 5% in the control group. It would be, that information is there, but you need to look carefully. And if you're briefly reading a paper, it might not jump out at you. I would submit that if we actually did baseline values, baseline testing on some of these trials, which would perhaps go back to that, certainly for cluster of trials, because if you did that, this is what happens. You get these huge p-values, tiny p-values of base. So we look at the socioeconomic status, which would be highly predictive of risk of pregnancy. We can see the p-value almost going off the page. It's so, the trial is so unbalanced and under these measured covariates that it's going to be confounded. And if we think of the unmeasured covariates, I mean, social status is one thing that is imperfectly measured anyway, because it's only a proxy. So we're getting this huge problem with an imbalance both in observed and almost certainly in unobserved variables. So I estimate there's 266 missing girls from the control group if compared with the intervention group, and if pregnancy rate was around 50%, which sounds high, but you know, we did a study on pregnant teenagers, and 66% of them got pregnant again within 2 years. So for some groups of people, that the teenage pregnancy rate can be quite high. So if it was high, and remember the missing teenagers are from groups that probably have a high incidence of pregnancy, then the simulators probably are off the hook for causing harm. Furthermore, if you delve into the paper a bit more, this is what they use for sample size calculation, which incidentally can't replicate, but we'll ignore that for a second. they find that there's a 16.8% pregnancy rate historically. And the intervention group was almost identical to what the historical, so the intervention group wasn't shifted either way. It stayed almost exactly what the historical rate was. It was the control group that got fewer pregnancies, resulting in the apparent harmful effect of the intervention. So there's no reasonable reason why the control group would have a lower pregnancy rate, because nothing was being done to them. They should shadow what was happening in the past. So that's more evidence that there was a problem with this study. So in summary then, cluster trials, they have been bad. They're still pretty awful. So what should we do? First, if you can do it, you should do an individually randomized controlled trial. Cluster randomization is only statistically more efficient because a lot of people do it for contamination reasons. So if contamination is a problem and you have to do cluster randomization, so the school that the trial we just talked about, you may have had to do cluster randomization and not do individual randomization, although possibly you could have done individual randomization. But if you had to do cluster, in that particular trial, it would have been easy. There were two things that were easily could have sorted that trial out. First, you could have approached all the girls and their parents before you randomized the schools, asked them if they would take part. About half would say yes. Then that's your randomized population when you randomize the schools. Or you could have just done what you've done now, but you include everybody in the analysis. So you collect pregnancy rates at a school level so you can preserve confidentiality, so you don't need to get individual data because it's a cluster trial. You can get the average pregnancy across a period of time by school. So again, but you would have included all girls in that analysis, not you would have included the 50% that are missing from the study. So to conclude across the piece, the significant proportions of randomized trials suffer from avoidable selection biases. There's no excuse for not doing adequate allocation concealment in this day and age. It's avoidable, and we've in a paper to the BMJ about it, I've suggested that the major journals should need to stamp it out by giving a date that they will not publish trials within 3 years that use sealed envelopes. So that's one way of stamping it or mitigating the problem enormously. And cluster trials, you either need to recruit before randomization or use the masked recruiter to do that. So that's the end of my talk. I apologize for the lack of intermittent internet connection. I've managed to boot my son off his computer, so that's why I do have a connection.
Not at all, David. You've done amazingly, and you know, when the line goes down and everyone is very patient. We all understand what it's like working from home at the moment and everything, but you've been brilliant because you just kept going. So that's really good that we were able to just pick up where you left off. So that's great, and everyone has managed to stay with us, so we're really pleased about that. So we have a few questions. If anyone has a question about the presentation, please put it in the Q&A. Oh, there we are, it's coming up now as the big slide. That's great. Put it in the Q&A box there for us. But we already have a few questions in, so if you're ready to take them, I'll fire away. So just get this one first of all. So this one comes from Abdul, and he's asking, how do we do the math when a trial has used variable block randomization? Let's say blocks of 2, 4, and 6 for a sample of 600. How do we identify flaws by looking at the imbalance?
Well, if it was if they just blocked across the whole trial and they didn't do any stratification, then it would be the maximum imbalance for that particular trial would be 3 because it's half the largest block size you use. The problem is, it's often difficult to tell. So if somebody stratifies by age and gender, for example, that's 2 stratification variables, and by centre, and you've got 20 centres, then it's half the block size across 20 in those 2 other stratification. So it's really difficult to tell then. So you can only do it when they tend to only do it when they don't stratify by centre. They have a single centre essentially. And if your 600 patient trial used 600, didn't stratify anything else and didn't stratify by centre, you would, if you saw an imbalance of say half a dozen participants, then there'd be a problem with it.
Okay. Brilliant. Okay, another question we have now is, so you mentioned the case example of the subversion in the surgical trial. Do you have any experiences of other trials being subverted?
Yeah, I mean, we had a PhD student working in our department once, and he was doing a randomized trial of rehabilitation for hip fracture. And so and enhanced the rehabilitation technique. And so he'd done just about everything right. He had was using distant randomization, so the nurse recruiting the patients was to ring him up and with the patient name, and then he would go on his laptop and generate an allocation. Unfortunately, he was using a single block size of 6, and it was just a single center. And after it went up fine for about 50 patients. Then the nurse was keeping a log of previous allocations. So, you know, clearly she didn't have enough to do, but because she was, so she kept this log and realized the pattern of 6. And so because she didn't have to randomize at the same time, she was recruiting from hip fracture wards, she could gather up several patients all at once, and then she could predict the allocations to some extent. And when she could, she made sure the patients that were the frailest went in the intervention group because she thought the trial was unethical. And then eventually the trial appeared to show that getting advanced rehabilitation made things worse. So it wasn't implemented, and the treatment wasn't implemented, to try and to subvert the trial has lost that particular thing.
Yeah. Another question here from Rashtam, and he's asking, or they're asking, what about the problem of selection bias in RCTs compared with the real world population? In other words, external validity, not internal validity, or is that for another webinar?
Yeah, I mean, external, internal validity, I've just sort of, quite frankly, I'm not particularly bothered about the differences, because in an ideal world, we'd take a random sample of people with a given condition and randomize them. That's virtually never going to happen, because we have to get informed consent. Most trials have to get informed consent. As soon as you have informed consent, some people say they won't go in. So immediately you have some kind of selection into the trial. But for external validity, you've got to have internal validity. So you've got to be clear that the intervention works before you can extrapolate. So it's no good having an observational study which appears to have, well, people say it has high external validity because we've got everybody who ever takes a drug compared with everybody, a similar group. Well, no, it doesn't, because you say it might work, but it's like the Lancet paper recently of chloroquine, isn't it, for COVID-19. No, it has external validity because it's recruited tens of thousands of people who've been treated in COVID-19 wards, but it has no internal validity because it's almost certainly got high levels of selection bias. So you don't have high external validity unless you have internal validity to start with.
Okay, very good. I'm just reading on here. I know we're at our time limit now, but could you spare another couple of minutes, David, just to answer a couple more questions?
Yeah, I'm happy to do that. Yeah.
Thank you very much. Okay, next question is, or a comment really. It says, "Hi David, thank you for persevering with delivering the webinar." And they agree with your good randomization is necessary for allocation concealment. The comment is, "I was surprised at your recommendation that block randomization should be replaced with simple / unrestricted randomization. There are many alternative restricted randomization methods, substantially less predictable, while maintaining maximum degrees of imbalance, e.g. blocker and big stick." This comment says, "I believe that we need restricted randomization in trials for logistical reasons and to avoid confounding with other time trends." So I would not throw out restricted randomization. I would look to use better approaches.
Yeah, I mean, I agree with that. I mean, I do use restricted randomization for those two reasons, the logistical reasons. So we do quite a few surgical trials, and surgeons do need to know that over, say, if you're comparing surgery versus non-surgery, surgeons do need to know how many surgical operations they're expected to perform over the next month, which if you do simple randomisation, you can't give them an accurate answer to that question. And also the time issue, again, is a problem if you're recruiting relatively slowly. Simple randomisation might give you, say, a long string of allocations to one of the groups over the summer period or winter period where there might be temporal effect, climate effects or whatever. And there are methods, big stick and other methods for doing that. But there are other methods for making randomisation unpredictable. I mean, there's another one that I noticed the other day. So we should look to these methods. We shouldn't. I mean, block randomisation stratified by centre is what most people do, and what most people do isn't correct. Yeah.
Okay. Okay. Another two more comments here. One from Declan's asking if recruitment of participants is a cluster needed before randomisation, what could lead? That could lead to delay between recruitment and randomisation, i.e., need cluster with sufficient number of participants eligible and consented. In conditions that have temporal effect, e.g. dementia, this could cause problems. Any thoughts on how we could address this?
Yeah, I mean, it's not just that, it's also, you might, so there was a cluster trial, for example, of training GPs on how to deal with patients with, I think it was an acute episode of depression, a mental illness. So you couldn't recruit them beforehand because the GP wouldn't. You could, if it was chronic disease, you could recruit them beforehand, but this was an acute episode of disease. So what they did was they took the receptionists from both groups of practices before, and they trained them on how to identify patients that pitched up to the surgery to see the GP. So the receptionist would make some inquiries when they're booked in to see their GP about why they wanted to see the GP. And if they were saying it was anything to do with depression, the receptionist then would try to recruit the patient to go into the trial. And so that is it's the same across the both groups. And the GP who was receiving the training was just, wasn't involved in the recruitment. So there are ways of dealing it, or you have someone who's blinded to the groups to recruit the patients, or so you can do it. It just needs to be thought about more carefully.
Yeah. Okay. And then lastly, I think the last question we've got time for today is from Sean, and he's asking, why do you think stratification, etc., allocation persists rather than just doing simple randomization and looking at sites, etc., in the analysis?
I remember some years ago having the same conversation with Martin Bland, and he, who's a professor in medical statistics, and he blames it on, ironically, on statisticians. Well, I think he did. Well, anyway, I do. I don't want to contribute a comment to him that he might not have made. Statisticians are like anybody else. They're very traditional. So a lot of the stats originated in the 1930s and Fisher and that lot, and they all blocked routinely because, I mean, I'm of an age where there wasn't calculators when I was at school. And I remember having to do a project calculating standard deviation stuff by hand, fairly mild statistics, and it took you hours. So trying to do a linear regression by hand is impossible. So within a century. So blocking made perfect sense, because if you blocked on climate, on crop yield or fertilizer dose, then absolutely you don't need then to do a regression. You could just assume it's balanced because you've met force balance. Whereas now we can use ANCOVA or regression methods. So I think there's a view that sort of retain that you just automatically block where you can and only randomize when you can't. So people do blocks without thinking, well, do we really need to block anymore? And I think the answer is it's not as essential as it used to be.
Mm-hmm. Very good. Do you mind taking one last question, because it's the last one there and I feel bad leaving it. This comes from somebody asking, for systematic reviews, would you mark a trial for high risk of selection bias for using any form of seal envelopes? I thought that was a quick one.
I'd like to, in some ways I'd like to say yes, but you need a good description of the sealed envelopes, and sometimes, so those reviews we've done where we've included sealed envelopes, there's been 1 or 2 we've put as an adequate group, because they've clearly said that the envelope has been opened by someone at a distance that's not involved with the trial. So, and we were going to do a trial of an ambulance study where there was quite a risk that patients of the ambulance would be out of contact. So from recollection, we had it using a hybrid system, mobile phone, but if they didn't have a phone signal, then there was backup with envelopes held in the ambulance. So there are some times when, you know, you can't do it any other way. And so it just needs to be careful to look at how, you know, how well the envelopes have been, you know, you can put carbon paper in envelopes to check that people haven't opened them. So you make people sign at the outside of the envelope, write the patient's name on the envelope before you open it, and use carbon paper underneath within the envelope to so that it's signed off before the envelope's open. So there are ways of doing it, but there are quite cumbersome. And most people don't say, they just say we use the sealed envelope method, and don't actually say that they had carbon paper inside, sign the envelope first. So there are ways of doing it to increase your security that you think it was done well.
Yeah, that's a good way to do it. Thank you so much, David, for taking that extra time to answer those questions and for bearing with us with these technical issues. It's really great. I hope it's okay. I've told everyone that we'll share the slides, if that's okay.
Sure.
And so that we have everyone can have it at home, and we'll organise it on the website. But it was really good of you to bear with us. And as I say, mark of a true professional to just be able to keep going. So hats off.
Okay.
And thank you to everyone else for joining us and staying with us. It was really great that everyone did. So there's nothing more to say now, except that we'll have more webinars coming up. We try to do it monthly, so check our website, and our Twitter feed is excellent as well for keeping up to date on what's going on. Yeah, stay safe. Thank you everyone for joining us.
Thanks so much.
Thank you. Bye-bye.
Bye.